Today we are going to discuss about antihypertensives, and particularly we are looking at the sympatholytics. These are drugs that aim at blocking either. So the sympatholytics which we are looking at, these are the ones that block either production of norepinephrine, or they block the norepinephrine from attaching to its receptors on the postsynaptic neuron that is in the central nervous system. And as we begin, we urge you to subscribe if it is your first time, like the video and share to many others. That is the only gift you can give us so that we can grow together. So we are seeing these sympatholytics. Their mechanism of action in general is that they can either block or they decrease the release of norepinephrine neurotransmitter, or they block its binding on the receptors. And these receptors include alpha and beta receptors, that is in the sympathetic nervous system. So that is what they do. And these sympatholytics, they are divided into three. We shall look at the beta blockers, beta adrenergic blockers. We are going to discuss about the alpha blockers, and we shall look at the centrally acting sympatholytics. Centrally acting. These ones which are the alpha-2 agonists. Majorly we use alpha-2 agonists. So these are the three classes we are going to discuss in this session. We are going to look at the beta blockers, alpha blockers, and the centrally acting adrenergic antagonists. So we are going to begin with beta blockers. We want to see how do they work. So number one, we are beginning with beta blockers. So these beta blockers, they are divided, or they are classified into three ways. But before we go to the classification, is that these beta blockers, they block both beta 1 and beta 2, depending on the classes we are going to see. So we're going to see that we have what we call the first generation beta blockers. We have the second generation, first generation. We shall look at the second generation, and we shall look at the third generation beta blockers. So the first generation, these ones, they are non-selective. These ones are non-selective for beta receptors. Whereas the second generation, these ones are cardioselective. These ones are cardioselective, meaning they target beta 1. These ones target beta 1 receptors found in the heart and in the juxtaglomerular apparatus of the kidney. That is why we find beta 1 receptors. Then the third generation, these ones are also non-selective. They are non-selective, and for them they have both beta action and alpha 1. So they can block both beta 1 and beta 2. At the same time, they have effect on the alpha 1 in the smooth muscles of the blood vessels. So these ones, they have both. But we have seen the first generation, they act both beta 1 in the heart and juxtaglomerular apparatus. At the same time, they work on beta 2 found in the smooth muscles of the bronchioles or the bronchus. And their mechanism of action, for example, these non-selective beta blockers, and examples include propranolol. Propranolol is one of the examples of the first generation. Pindorol, timolol, timolol is also part of it. Then sotalol. So all these four examples are first generation beta blockers, which are non-specific, targeting both beta 1 and beta 2 blockers. So what is their mechanism of action is that in the normal situation, we see the baroreceptors, which are found in the carotid and the aortic, sending impulses to the tractus solitarius, which controls the cardiovascular center. And after sending impulses, then these impulses are brought via the efferent, that is the cranial nerve 9 and the cranial nerve 10. And when they are coming, they have the receptors on the sun and also at the AVN node. That is where they send their impulses in response to increasing blood pressure. So this is the sympathetic nerves. So what are the beta blockers? Another thing, these ones can send also impulses to the adrenal medulla, which is responsible for production of norepinephrine and epinephrine. Those are the catecholamines. And at the same time, it can send also impulses to the blood vessels, but this is via alpha 1, which we shall discuss later. But it can also send impulses to the alpha 1 receptors, to the beta 1 receptors within the juxtaglomerular apparatus, stimulating production of renin. So what these beta blockers do, which are non-selective, they come and block the attachment of norepinephrine on the sun, that is beta 1 receptors and AVN. At the same time, they also block their attachment on the adrenal medulla, so that there is no stimulation of the sympathetic outflow. So this one is the block. We are seeing they block the receptors on the postganglion or in the beta 1 receptors in the heart muscles and the juxtaglomerular apparatus. But this one has beta 1, which we shall see it under cardioselective. So that is their mechanism of action, by blocking the binding of norepinephrine neurotransmitter. And as we know that these beta 1 and beta 2, they are G-stimulatory. When blocked, meaning there is no contractility. So after blocking the sun, there is no depolarization and no contractility. So they end up decreasing heart rate. And after decreasing heart rate, they also decrease stroke volume, leading to decrease in the cardiac output, and hence we can overcome the problem of hypertension. Then the cardioselective examples include the atenolol. We have a simolol, we have acetabolol, these are cardioselective. They only bind to the beta 1 receptors in the heart. So atenolol, simolol, then metoprolol, also metoprolol. These are the 4 agents which are cardioselective. For them, they bind only to the beta 1 receptors in the cardiac muscle and the juxtaglomerular apparatus of the kidney. So we are saying this cardioselective, they only block the beta 1 receptors in the heart muscle and in the juxtaglomerular apparatus of the kidney. And when they do that, after blocking the attachment of norepinephrine on the beta 1 receptors in the heart and the kidney, they inhibit contractility, that is, they have ability, they inhibit or they reduce cardiac output by reducing heart rate and stroke volume. And at the same time, they inhibit release of renin, and meaning they inhibit production of angiotensin 2, which is a strong vasoconstrictor, hence decreasing total peripheral resistance. So this one acts by decreasing both cardiac output and decreasing also vesicular resistance. That is their action. Whereas these ones, they only have ability to decrease cardiac output. They decrease cardiac output, and they also cause bronchoconstriction. So meaning these ones are contraindicated in asthmatic patients and COPD. So we are seeing that the non-selective, they are contraindicated in patients with asthma and COPD because they can act on the beta-2 receptors in the respiratory system, leading to bronchospasms, which is dangerous in people with asthma and chronic obstructive pulmonary disease. So this is what we can look at under cardioselective. Then the third generation, which is non-selective for both beta and alpha-1. So meaning it also acts by blocking both beta receptors and alpha-1 receptors. And examples include labetalol. We have labetalol is one of the examples, labetalol and carvedilol. So these are the two examples under third generation. Even we can add noviberol. So these ones, for them, they have activity. They can block the beta receptors that is in the heart and in the kidney, stopping contractility and also stopping decreasing vesicular resistance by causing vasodilation. Because if there is no angiotensin II due to the action of renin, there is vasodilation which decreases total peripheral resistance. So this one does both. So their problem is that when taken, because they are decreasing both cardiac output and the vesicular resistance, we can see problems of some of the side effects they can bring about is rebound hypotension, or sometimes they can cause tachycardia, reflex tachycardia. This is one of the side effects. Reflex tachycardia and cardiac arrhythmias. These are the side effects of these drugs. Labetalol is the best drug which we can use in treatment of patients with pregnancy and at the same time with hypertensive emergency. Then these ones we have seen, we are indicating them in treatment of hypertension, people with heart failure, and patients with cardiac arrhythmias. Cardiac arrhythmias, heart failure, and hypertension, we can easily use cardioselective drugs for treatment of those conditions. Then we are seeing the propranolol, pindorol, and timolol. For example, timolol is used in treatment of glaucoma. It is topically applied on the eyes for treatment of also glaucoma, apart from treatment of hypertension. Then these are the things we can talk about. This one we have seen also their indications in treatment of chronic hypertension, especially emergency, hypertensive emergency, that is labetalol. Though it is not selective, there is a problem of causing tachycardia. Then the non-selective for beta, they can induce asthma and COPD, are so contraindicated in patients with non-asthmatic patients and COPD patients. That is what we can discuss under beta blockers. The next class we are going to discuss with you is the alpha blockers, the alpha antagonists. These alpha antagonists, they are also divided into two. We have those ones which are selective for alpha, and those ones which are non-selective. And among the selective, we have example of these ones. They are specifically for alpha-1 receptors found in the smooth muscles. And examples include plazosine, then terazosin, and doxacin. So these are drugs which can be used in the treatment of hypertension, and their mechanism of action, for them, they bind on the alpha-1 receptors in the blood vessels. The smooth muscles of the blood vessels have alpha-1 receptors which work under G2, meaning when the norepinephrine binds on the alpha-1 receptors, it leads to production of DAG and IP3. These are second messengers which can increase contractility of the smooth muscles of the blood vessels, leading to vasoconstriction. So what plazosine, telazosin, and doxacin do, they come and block the binding of norepinephrine on the alpha-1 receptors on the smooth muscles of the blood vessels. And when they broke, there is no production of IP3 and DAG, hence decrease in causing relaxation. It causes relaxation of the blood vessels, leading to vasodilation. And when there is a vasodilation, this one will decrease peripheral resistance. They decrease peripheral resistance, which can decrease preload, leading to decrease in blood pressure. So these ones, they are vasodilators. They cause vasodilation of the blood vessels, hence decreasing peripheral resistance, which at the long run decreases hypertension. That is plazosine, telazosin, and doxacin. And among these ones, these are long-acting, whereas plazosine is short-acting, and they are indicated, these ones are indicated in patients with hypertension. If patients have hypertension at the same time with BPH, that is benign prostatic hyperplasia. So if someone is hypertensive with benign prostatic hyperplasia, you can opt for plazosine, telazosin, and doxacin. But their problem is that their ADR, they cause orthostatic hypertension, orthostatic hypotension. Because as they decrease peripheral resistance and preload, they can lead to what we call bradycardia. This one is due to bradycardia. So whenever you are always seated in a position as you're going to stand, you can easily fall because of this change in the position, which is what we are calling orthostatic hypotension due to plazosine, telazosin, and doxacin. But they are preferred because they don't cause hyperlipidemia compared to beta blockers. Beta blockers, another side effect is that they can increase triglycerides, which lead to hyperlipidemia, which is a risk, but these ones do not cause hyperlipidemia. And they have a good effect on treating benign prostatic hyperplasia. That is what we can discuss about this. Other classes and alpha-1 selective, we have tamsulosin, silodosin, but those ones, they have less effect on treatment of hypertension. They are only good at treating benign prostatic hyperplasia. That is tamsulosin and silodosin, which are also part of alpha-1 selective blockers. So in hypertension, we are dealing with the plazosine, telazosin, and doxacin, which cause the vasodilation by binding to alpha-1 receptors in the smooth muscles of the blood vessels, leading to increase in the peripheral resistance, which can lead to decrease in the blood pressure. Then the non-selective, these ones bind both on alpha-1 and alpha-2. And examples under this class, we have phenoxybenzamine, then we have also phentolamine. So these are non-selective alpha blockers. This one is short-acting and it is reversible, whereas phenoxybenzamine is irreversible. This one is reversible. It has longer duration of acting, 24 hours. This is 2 to 4 hours. So phenoxybenzamine and phentolamine, being non-selective, they are being indicated in the treatment of pheochromocytoma. That is, increase the release of catecholamines from adrenal medulla. So what do these phenoxybenzamine and phentolamine do? They go and inhibit the action of beta-1 receptor, which is going to trigger production of these catecholamines, which is pheochromocytoma. So we can use them in the treatment of pheochromocytoma, which leads to hypertension, or during surgery of the tumor, which is causing overrelease of catecholamines. So this one is majorly indicated in treatment of pheochromocytoma or secondary hypertension due to pheochromocytoma. That is phentolamine and phenoxybenzamine. Then lastly, the last class we are going to talk about is the centrally acting adrenergic agonist, adrenergic antagonist, or blockers. These ones, as the word suggests, they work in the CNS, that is majorly the brain and the spinal cord, whereby these centrally acting adrenergic antagonists include majorly the alpha-2 agonist. And the alpha-2 agonist we have here is clonidine, and alpha-methyl dopa. Then we have other classes like VMAT blocker, that is reserpine, but which is not commonly used. Reserpine is not commonly used. So the commonly used is clonidine together with alpha-methyl dopa, which is a prodrug. So we are seeing these centrally acting, for example, the alpha-2 agonist, they come and bind on the alpha-2 receptors presynaptically. Alpha-2 receptors are found presynaptic on the presynaptic neuron, and they are G inhibitory, meaning when stimulated, they come and inhibit release of neurotransmitter. So they come and inhibit release of norepinephrine from the presynaptic neuron into the cleft. After blocking the release of norepinephrine, so the norepinephrine is reduced, so there is no norepinephrine to bind to the postsynaptic receptors. Hence, we are able to block the sympathetic outflow. And this centrally acting adrenergic antagonists, they are being used majorly in the treatment of hypertension due to drug withdrawal syndromes. If someone has been taking alcohol or benzodiazepines or cocaine and they have been stopped and they are getting hypertension due to the withdrawal of these drugs, we can easily treat them using clonidine or alpha-methyl dopa. So clonidine is used majorly in the treatment of hypertension due to withdrawal syndromes. To people who have been on addictive drugs like cocaine, benzodiazepines, and alcohol. Whereas alpha-methyl dopa is a good agent in the treatment of hypertension in pregnancy. So it is being used in treatment of hypertension in pregnancy, and we say that this one is a prodrug. So when given, it is converted into an active metabolite, that is methyl norepinephrine, which is able to treat hypertension in pregnancy. And at the same time, it can also treat withdrawal syndromes on the patients who have stopped benzodiazepines, opioids, and alcohols. Risapine, we said, is not commonly used. The commonly used one is clonidine and alpha-methyl-dopa. Their major side effects, since they are blocking the production of norepinephrine, they can cause sedation. They can also cause dry flushing or dry mouth. They can also decrease libido. They can decrease libido because they are preventing production of epinephrine and norepinephrine. So this is their major side effects. And even when the patients are on these drugs like clonidine and alpha-methyl-dopa, stopping should be gradual. When stopped immediately, they can cause what we call rebound hypertension or compensatory hypertension, because they can lead to tachycardia when stopped immediately, what we are calling rebound hypertension. So whenever patients are on this treatment of the clonidine and alpha-methyl-dopa, it should be stopped gradually to prevent rebound hypertension. Also be aware of sedation, dry mouth, and decreased libido. That is their side effect. And don't forget that clonidine withdrawal syndromes, then methyl-dopa, that is treatment of hypertension in pregnancy. So this is basically what we can discuss with you under sympatholytics, where we have looked at the beta blockers, we have looked at the alpha blockers, both selective and non-selective, then we have ended with central acting adrenergic agonists. So we have seen their indications, we have looked at their mechanism of action, and we have seen the indications and the contraindication. Don't forget that these non-selective beta blockers are contraindicated in asthma and COPD. And another thing to note, we have to know those which are non-selective and those which are selective, which we have seen here, and their mechanism of action. Then we have seen under alpha blockers, the prazosin, terazosin, that their major effect is orthostatic hypertension. But why are they preferred? That they have addition of reducing benign prostatic hyperplasia. At the same time, they do not cause hyperlipidemias. Then with the phenoxybenzamine and phentoramine, they are used for treatment of pheochromocytoma. But phenoxybenzamine is very dangerous because it is irreversible. So we prefer phentoramine, though they are not commonly used. But they can use them if there is someone for tumor surgery of the adrenal medulla in the treatment of pheochromocytoma. Then we have seen clonidine, treatment of withdrawal syndrome, methyl-dopa, hypertension in pregnancy. Thank you so much for learning with us at Medical Sciences. Thank you so much.